have a little trick for you.
Okay.
So if you get a lot of sun exposure during the day, sometimes I'll use an anti-inflammatory at night to kind of calm the skin down. So those are generally prescriptions, but there are a lot of either topical steroid like hydrocortisone, but now we have lots of steroid-free anti-inflammatories that are safe on the face. So I will tell my patients, if you're going to spend the day on the boat, that night and for the next few days, use anti-inflammatories, because I always say when we're managing melasma, we want the melanocytes to be fast asleep. We want the skin to be fast asleep. So you don't want your skin to be in this pro-inflammatory state. So I always tell my patients, if you're going to spend a lot of time outside at night, use something anti-inflammatory, really calm it down.
Welcome to Glow Lab. We're going to have a lot of fun and learn a lot together. If you've followed me for a while, you know I've dealt with melasma for years, going on more than a decade at this point, and I've done lots of treatments, used all the different ingredients, all of the things. So today's topic is all about hyperpigmentation, and my guest is Dr. Heather Woolery-Lloyd. She is a board-certified dermatologist in Miami. She's also a friend of mine. I love chatting with her. She has this really cool platform called Derm Friends, where you can sign up and get this newsletter, and it has so much information about skincare. So if you're a skincare person, you're gonna love it. She is here to talk about hyperpigmentation and all the treatments and melasma and just everything that has anything to do with hyperpigmentation. I feel like I learned a lot in this conversation, which is a big one for me. I learned about new tricks and even new ingredients. So you're gonna really love this conversation. This is a great topic, and people know me for hyperpigmentation because I have dealt with melasma for so long, especially after having babies. And a lot of the time people are like, how did you get rid of your melasma? Which they don't realize I have never gotten rid of it. I still deal with it. I always know that if I'm like out on a boat or something, I'm gonna go home that night and my face is gonna be a little more freckly and a little bit more discolored and stuff. But now I know how to kind of deal with it for myself. So I feel like this is a topic, hyperpigmentation in general, is just a fun topic because there's just so many factors and things that people can do with it, right?
Yes. So I totally agree with everything you're saying because it's a challenge. It's one of the things, if you're in a dermatology meeting with a bunch of dermatologists, when the topic of melasma comes up, everyone's like, oh no, because it's really one of the hardest things that we treat in dermatology. And you're right, it's something that we can manage, but there's no quote unquote cure. The good thing about melasma is that people do tend to grow out of it. So in your 30s, 40s, 50s, we can manage it, but there's not a lot of 60 and 70-year-olds walking around with melasma. So that's the only good thing. That's the silver lining, I can tell you.
Once I get older, that's one less thing I have to deal with.
That's our silver lining, but it definitely is a challenge. But there are lots of great treatments that we have that can manage melasma. And if you approach it the way you approached it, that's why I kept nodding my head, which is that you can get it under control. You know that if you're going to go out on a boat, it's going to get a little bit worse. You're going to be a little more proactive on those days that you're going to get more sun exposure. Those are the patients who do the best.
Right. Right. And probably knowing their triggers too, right?
Exactly.
Like for me, I know that if it's like a really hot day, whether I'm in the sun or not, it's going to start to flare a little bit. And I know that like if I'm sick, for instance, like when I like something that causes like inflammation in my body and I turn red, I know it's gonna get worse for some reason. So
yes, melasma gets worse. Everyone knows their own triggers, but it definitely gets worse with heat, with sunlight. I do think even if you don't get sun on your face, there's this concept that sun on the body can trigger melasma on the face. So if you theoretically walked around with a mask, I have a lot of patients who say, I promise you, I didn't get one drop of sun on my face, but they got sun on their body and it activated the melasma on their face. So people definitely know their triggers, and it's something that it requires a lot of navigation treating melasma, but it is one of my favorite things to treat.
Yeah. Well, that's good to know. Wait, before we even get deeper into melasma, hyperpigmentation can be so many different things, right? Can we maybe talk about just what hyperpigmentation is first?
Yes. So hyperpigmentation is just the medical term for dark spots on the skin. It can be dark spots. It can be dark patches. It can even be general uneven skin tone. That's probably the most common thing I treat in my practice. And there are different types of hyperpigmentation. So we just talked about melasma. We can also see post-inflammatory hyperpigmentation. The most common cause is after acne.
Right.
Or women who maybe have facial hairs and are plucking hairs, the dark spots that are left left after any little irritation in the skin. In South Florida, after mosquito bites,
Right.
So anything can really cause post-inflammatory hyperpigmentation. And then we have sunspots, so the dark spots from the sun. And something else that I see a lot of in my darker skin patients is that general uneven skin tone that develops with age. So women in their later 50s, 60s, and 70s sometimes will just get general uneven skin tone, and that's a form of hyperpigmentation too.
Would you say even the uneven skin tone under the eye, like dark circles and stuff, that's a form of hyperpigmentation?
As if it's darker than your surrounding normal skin, that's hyperpigmentation.
Okay, so who are the people that are most prone to it, and what are some of the ways that we treat it?
I would say the people who are most prone to hyperpigmentation are darker pigmented people. So in dermatology, we use Fitzpatrick skin types 1 through 6. I would say Fitzpatrick skin types 4 through 6 are at the highest risk for developing any type of hyperpigmentation, although skin type 3 can sometimes get hyperpigmentation too. Yeah. So in certain ethnicities, so obviously in Black, Latina, Asian, some Mediterranean populations are much more likely to develop hyperpigmentation. And it's something that if you live in a sunny climate, so maybe you're not prone to it. I've had patients who lived in New York, moved to Miami, and they said, I never had this before when I lived in New York, but our sunny climate, that very high UV index also increases your risk of hyperpigmentation.
And is that just because when you have more melanin in your skin, then your body has a higher chance of just overproducing melanin?
Exactly. So basically, I always say we have these cells in our skin called melanocytes, and they're a factory that make melanin. And that factory turns on and is very efficient the darker your skin is. So any irritation, any scratch, a bump, a pimple, any irritation turns on that factory, and then you get that hyperpigmentation.
I like that you use the word efficient. It makes it seem like so much better. Like
very efficient.
We're getting hyperpigmentation because our skin is efficient.
Very efficient at making melanin. So the more efficient you are, the benefit is that, having a lot of melanin in your skin also delays aging because you have some internal protection from the sun. You're not completely protected, but there is some internal protection from having melanin in your skin. So that's the benefit. The downside is that any irritation, any inflammation can lead to hyperpigmentation. And you're also at risk for other conditions like melasma, which can be hormonal, but is made much more worse by the sun. So that's the downside.
Melasma seems like hormones for sure. I know that I have hypothyroidism, so I know that can sometimes make it worse too. Why is it that melasma is so hard to understand versus I feel like I've taken my mom in to get laser treatments, right? And I'm like, she's got melasma because I'm just assuming she's like me with melasma. And they're like, no, these are sunspots. And I'm like, well, what's the difference? Why is it that I'm getting melasma and she's getting sunspots? So
melasma is something that we see usually in the 30s, 40s, or even in the 20s if someone has a baby, right?
Yep.
It's heavily driven by hormones. They used to call it the mask of pregnancy. And you would get basically these 2 little patches on your cheeks, sometimes on the upper lip, and then sometimes on the center of the forehead. So definitely with pregnancy and these changes in hormones, we see this mask, right? The mask of pregnancy. A lot of women, it goes away when they have their baby, but a lot of women, it persists. And patients will tell me, I developed this after I had my first child or my second child. So melasma is a little bit complicated. Like I mentioned, it's not the easiest type of hyperpigmentation to treat. I feel like the pigment of melasma wants to be there. It's like it's set up its house, and you're the battle when we're treating melasma is trying to kick it out of its house. But the second that you kind of give it a little break, it resets up, starts nesting, and wants to be in its house. So that's the difference with melasma, is that pigment has a drive to want to be there. Whereas with a sunspot, like you were mentioning with your mom, we can use lasers in the right patient, not in all patients, but in the right patient. And when you superficially remove that sunspot with a laser or some sort of device, it kind of gives up. It's not going to repopulate. It's gone. Whereas melasma, I feel like the melanocytes or the pigment of melasma sets up its house.
It's deep in there, right?
It wants to be there. Yeah. And so it's a little bit of a battle to kind of kick it out. But that's the main difference, is that there's a constant drive to repigment even after it's cleared.
Let's talk about post-inflammatory hyperpigmentation and the ways to prevent it and the ways to treat it.
So for post-inflammatory hyperpigmentation, the best way to prevent it is to avoid anything that causes hyperpigmentation. So plucking on the face is a common cause. So, choose laser hair removal or some other method that is not as disruptive to the skin. With pimples, try not to squeeze pimples. That's a big common cause. Although I will say many people who don't squeeze their pimples at all will still develop a dark spot from that pimple, but it will be significantly worse if you're kind of digging around in
then
there.
You're like causing it to like
yes,
spread everywhere.
Exactly. Yeah. So avoiding trauma to the skin. And then to treat it, it's actually one of the easier things to treat, post-inflammatory hyperpigmentation. So we have many different things. I know we're going to talk a lot about treatments, but if something is simple and straightforward, we still as dermatologists use hydroquinone. It's still considered the gold standard and it's a quick, easy fix. That being said, we have many new treatments that are hydroquinone free. Mm-hmm. But one of the reasons why hydroquinone can be helpful for post-inflammatory pigment is that once it's treated, it's gone.
Right.
So the main issue with hydroquinone is that it can't be used long-term. That's why you have to be more careful in patients with melasma, because melasma is more of a chronic condition that you have in your 30s, 40s, and 50s. So we sometimes don't love to use hydroquinone because you don't really want to use that medication for 10, 20, 30 years continuously. We actually, in my practice, I only use it for 4 to 6 weeks. That's how I practice. So the benefit with post-inflammatory pigment is that you can use hydroquinone because it's a quick fix. Once the dark spot is gone, it's gone. You don't have to keep treating it like you do with melasma.
Right, I see.
But we do have alternatives, and I will say I do use much less hydroquinone now than I did 10 or 15 years ago.
So what would be some of those alternatives?
So there's some new ones that are on the market. One of the most recent ones that launched is called thiamidol. It's an ingredient that's in a product called Eucerin Radiant Tone, and it's actually been available around the world for the last 7 years. It's been a big component of what people around the world have been using to treat pigment, but we just got it here in the US. It works by inhibiting tyrosinase. Tyrosinase is the enzyme that is the most critical enzyme in the manufacturing of melanin.
Right.
So if you inhibit tyrosinase, you reduce melanin in the skin.
Because it can't create it.
Exactly. So what made it unique is that it inhibits human tyrosinase. So all of the active ingredients that we know of that inhibit tyrosinase have been tested on mushroom tyrosinase, because mushrooms have tyrosinase. That's why they turn brown.
Okay.
And the scientists who were working on this ingredient found an assay to look at what inhibits human tyrosinase, which is actually quite different than mushroom tyrosinase. And they found it to be a really potent inhibitor of mushroom tyrosinase. And so they, kind of developed this product around this active ingredient, and it works great. I've been using it in my practice.
Wait. Is this something you can get just like at the store?
Yeah, it's over the counter. Oh. Everything I'm going to talk about is over the counter.
Amazing. I love that.
Because really the only prescription to treat hyperpigmentation is hydroquinone. Mm-hmm. So everything else is over the counter.
Why is it that hydroquinone is prescription and not these other ones?
Well, hydroquinone comes in different strengths. So the 4% is the prescription strength, and then 6 and 8 and 10% can be compounded, which is what I typically do in my practice. Mm-hmm. However, 2% used to be available over the counter.
I remember that, yeah.
But now it's no longer available. I think it's because it's very hard to go after, from a pharmaceutical standpoint, to go after treating hyperpigmentation and melasma. Like I mentioned, it's one of the most challenging conditions to treat. So it's much easier to develop new topicals that are available over the counter. So thiamidol is one of the new ones. There's another one called Melasil that's in La Roche-Posay's Mela B3 serum. And that works by kind of quenching the melanin precursors. So also in clinical studies, it works really well. Both of these in clinical studies have been shown to be equivalent to hydroquinone.
Okay.
So even though dermatologists still consider hydroquinone the gold standard, there are things that are kind of creeping up on it, as far as efficacy is concerned.
And that people can stay on.
That you can stay on long term, which is for me very helpful because I'm treating melasma in Miami, where it's probably the most challenging city I feel like in the entire country, maybe other than Hawaii, maybe,
right,
to treat it because we have such a high UV index here.
And it's also just so hot.
So hot and sunny all year. There's no winter.
Right.
It's warm and warmer.
Right. That is absolutely true.
So Melasil is another new ingredient that I use a lot in my practice. Works great. Doesn't lighten the surrounding normal skin. One of the biggest challenges with hydroquinone, if you're treating a dark spot, is that you can get a halo around it. I call it the hydroquinone halo. So that can be a challenge if someone someone has, 25 dark spots from acne, they don't want 25, like the dark spots lighten, but also they get a halo of hypopigmentation. It sounds like that's happened to you before.
Oh, yeah.
So these products don't do that. So that's another new ingredient.
And I'll throw out there, I feel like hypopigmentation, you get that and you're like, you don't know what to do with that.
Yeah. Luckily, that usually resolves.
Yeah.
But it definitely, it's not desirable. It's not a desired outcome. Tranexamic acid is a hot topic, I would say, because in dermatology, we can use it orally to treat melasma. So within a pill form, we can use it with microneedling, and that's commonly done. And then we find it in over-the-counter topicals. Usually it's not a standalone. Sometimes it is, but usually it's combined with other ingredients to treat the pigment. So that's another very hot ingredient. There's an ingredient called lotus sprout extract. That one you might not have heard of, but it works by breaking down the melanosomes. And so I feel so lucky to be practicing now because I've been treating pigment for 20 years.
Yeah.
And, 20 years ago, when patients came to me with a challenging case of melasma or a challenging case of hyperpigmentation, I didn't have many things to offer my patients. I basically just had hydroquinone, vitamin C, kojic acid. Kojic acid is great, by the way, but that's one of the things I had. And now I feel like I have so many things to choose from. So it's a really exciting time.
What do you think about like the exfoliants, like the AHAs, glycolic acid, lactic acid? What do you think of ingredients like that for
So I think those are very helpful if you, as an adjunct. They're not like my mainstay. Someone isn't going to come to my practice and say, I have melasma, and the only thing I'll give them is an AHA, but it can be an adjunct. So they could have a glycolic acid cleanser or a glycolic acid toner as part of their skincare routine. But the problem with hyperpigmentation is that it is really a challenge. So I usually am using multiple different agents. So their cleanser, they might be using one serum in the morning, a different serum at night. We haven't even gotten into sunscreen yet, which I know we're going to talk about soon. But I really try to attack the pigment from so many different pathways to get the best results because it is such a challenge.
Yeah. Well, let's talk about sunscreen because I feel like that's the one that people seem to still overlook. They'll tell me they've done all these treatments, they've used all these ingredients, and then I'm like, well, how about the sunscreen? They're like, oh, I don't wear my sunscreen.
It sounds like you're like a fly in the wall in my practice because this is something I talk about all the time. I always explain, listen, if you're treating hyperpigmentation, if you're not using sunscreen, it's like pushing a rock uphill. Mm-hmm. So sunscreen is the most important part of my skincare routine. Actually, it's more important than even the topicals that are treating it, because if you're not protecting yourself from the sun, then it really is, you're not doing anything, really. So when it comes to pigmentation and specifically, we want ideally a tinted sunscreen. And the reason why is because tinted sunscreens protect against visible light. So visible light, I always try to explain to people, is the wavelengths of light that are, when we were in third grade and your third grade teacher put a light through a prism and you saw the rainbow come out, that's what visible light is. And certain wavelengths of visible light, specifically blue light, drives pigmentation. So specifically, blue light turns on the melanocytes. Those are the cells that make pigment, and causes that factory to become very efficient.
Yeah, no, that makes complete sense.
So the blue light that comes from the sun, and 50% of sunlight is visible light, right? So that blue light drives pigment. The reason why this is so important is because years ago, people would say, I'm so compliant with my sunscreen. I use it every 2 hours. I stayed in the shade. I did everything right. And I still developed melasma. It still got worse. My melasma flared. And it didn't make sense to us as derms because the person was using a nice broad spectrum UVA, UVB, SPF 50, or even an SPF 100. But the interesting thing is that even a broad spectrum UVA, UVB sunscreen is not protecting against visible light. And visible light is what we found out in recent years, is one of the major drivers of pigment. Yeah. So you want it to be tinted. Tinted means it has iron oxides. So the big challenge that comes up when something is tinted is it has to match your skin tone, right? Because obviously a tinted sunscreen that works for you is going to be very different than a tinted sunscreen that works for me. So I usually recommend to my patients, find a tinted sunscreen that you want to put on that matches your skin type, because that is what's going to protect you from visible light.
Yeah. I'm going to plug my sunscreen from my brand because this was something, since I deal with melasma, that was really important to me. So we developed the untinted version with an ingredient that actually does block the visible light. Yes. But then we've created a tinted version as well. So then you get the iron oxides with that other ingredient that is blocking the visible light, because it's so important to me.
You do bring up a good point. So the main way we know how to block visible light is with iron oxides, but there are some antioxidants and other ingredients that we can add to sunscreens that have been shown to protect against visible light.
Yeah, this particular ingredient almost gives a reflective, it's like a reflective property. And then it also in turn makes the skin look glowy. It's our Dew Glow sunscreen.
Love that.
It gives this dewy look, but it's not actually dewy. It's just that it's got this reflective property.
Yes. So that is something that's so important. And that's why if someone has been treating their hyperpigmentation and they say, I'm not getting anywhere, one of the key things you can do is switch to a tinted sunscreen or a sunscreen that protects against visible light.
Yeah.
Because that is the driver, especially if you live in a sunny climate like Miami.
Would these kinds of treatments also work for sunspots?
So sunspots are a little bit different. Yes, they can, but procedures are usually a little bit better for sunspots.
Okay.
So sunspots are the layman's term for solar lenticles. That's what we call them in dermatology, which basically means sunspot. But basically, they tend to do better with a procedure. Usually, we'll do light procedures like intense pulse light is really good for those. I actually don't do those procedures in my practice because my patients tend to be darker skin, and those procedures generally are not as safe in darker skin types. So ironically, for sunspots, I'll refer to someone else in the right patient. Usually Fitzpatrick skin types 1 through 3 are where you can treat the sunspots with laser or light device. But luckily, those are the patients, especially skin types 3, are the ones who tend to get a lot of sunspots.
Yeah, that makes sense. I think I'm like I don't know. Right now I have like probably no sunless tanner on right now. So I what would you say I am? A Fitzpatrick 2? 3?
No, you're like a 3 to 3.5. Okay. And the reason why I say that is because there are many lasers that we can't do in your skin type.
Yeah, I know.
So like it's almost like you're a 3, 3.5, but I would treat you as a 4. You would not be a candidate for many different lasers because I would be worried about the side effects. And I'm going to explain why that is, because when people hear that, they'll understand. So basically, the laser is targeting pigment. So if it can see the brown spot, but it can't distinguish the brown spot from the surrounding brown skin, it will also burn the surrounding brown skin. So lasers for brown spots work best in people with lighter skin and a dark spot because they're sensitive enough to see the dark brown spot, but they won't burn the surrounding normal skin.
Because the brown spot is clearly there against that skin tone. And
also because their skin is light enough that it doesn't pick up the heat energy from the laser.
That makes sense. I mean, I've experienced this. I think like, you know, I've just been around so long and like been the guinea pig in a lot of practices because I've worked with so many derms. You know, I've definitely been with like really great derms who at that point we didn't know like this new laser, who could it be used on and stuff.
Yes.
And then I end up with like a mustache, like a melasma mustache or a hyperpigmentation mustache because we've used a laser on me. So I got a little wary of lasers. And it wasn't until a few years ago that I even allowed lasers on my face.
Right.
And it wasn't until I found a dermatologist that she's Indian. So Dr. Nina Desai in Los Angeles, she is she's very aware of what can be done to my skin tone, because I think it is tricky. I think like some people see my skin tone, they're like, oh, she's light, she's fair or something like that. But they don't realize like there's this underlying skin tone in there. So you bring up a very good point. If you're struggling with melasma, you definitely want to see someone who's very experienced in skin of color, because I like I mentioned, I don't do lasers for melasma because also I'm in Miami, and believe it or not, Miami has a much higher UV index than Los Angeles. So you're really fighting an uphill battle down here. But if you choose to do a laser, make sure the person is really experienced in skin of color or darker skin types, because then, you know, you at least increase the risk that you're not going to have the side effects that you had in the past many years ago. Yeah, it's awful because actually when you get hyperpigmentation because of a laser, I feel like that was the hardest hyperpigmentation to get rid of. Yeah. We call that rebound melasma. So, you know, where I practice in Miami, it's very challenging to do lasers for melasma. So I actually stay away from it. I actually do more chemical peels. That's my treatment of choice down here. But in very skilled hands, like your doctor, there's a handful of doctors that I would trust. In very skilled hands, I think it can be effective, but you really have to find the right person who has lots of experience in your skin type. And I'll throw out there, doing lasers with her, because she's being so careful, is a longer process.
Of course.
Like I did Cosmelan with her as well. And I felt like after I did Cosmelan, I was like, why didn't we just do this in the first place? Because that got rid of so much hyperpigmentation.
Yeah, exactly.
Whereas like I was going through like 3-4 sessions of doing like a picosure or something,
you know? Exactly. Yes. So peels are my favorite. I love chemical peels, and there are many different types of chemical peels. Cosmelan is one of them. I do a lot of salicylic acid peels and glycolic acid peels. The key with peels is that some peels like Cosmelan is kind of a quick fix. Others, you can be more gradual. I'm very risk averse, so I tend to use the more gradual peels.
Yep.
I mean, it has a lot to do with where I practice. I have
course.
zero margin of error, you know, in sunny South Florida. So,
perfect.
So I typically do salicylic acid peels or glycolic acid peels, 20 to 30%, do a series once every 4 weeks for around 3 to 5 treatments, and we see really great results.
Yeah, I love that. I feel like lasers are such a big deal right now in different practices that it feels like it gets pushed a lot. And everyone's always like DMing me and they'll ask about specific lasers.
Right.
And I'm always like, why aren't they asking about chemical peels? Because those are still really great for hyperpigmentation.
And I find that they're predictable. They have a lower rate of side effects. So if you're risk averse, it's not that, and I'd never say lasers are bad, but you need to understand the risks. I always tell this story. We have sometimes doctors who will come and visit us from other countries, and they had a laser that was popular at the time for melasma. And I said, oh, you know, I don't really do that here. I'm worried about the rebound melasma. And that doctor said, oh, it's not common. It only happens like 30% of the time.
30?
For
that
me,
to me is high.
To me, that was high. So for me, I was like, oh no, I could never do anything. So it really depends on your personality type. So based on my personal personality type, which is very risk averse, and then patients who come to me tend to be very risk averse, they like a gradual improvement over time. It's not that that laser isn't a good choice. It's just that you have to understand the risk of your melasma getting worse can be, in some studies, as high as 30%.
Yeah.
So if you feel comfortable with that, great. But if you don't, then there are other options. My patients with melasma who are the most successful have strict sun avoidance, I would say sunblock, sun avoidance. So if you're going to spend the day on a boat, for example, in Miami, you're going to have a wide brim hat, 4 inches all the way around, covering everything, not just a baseball cap. If you're going to put on now we have really great tinted mineral sunscreens. I used to say you want that thick white, the old fashioned zinc. And I'm like, you know, my patients with melasma, they don't want their melasma to flare. So in some ways that probably might block visible light because it's just like thick white.
It's like nothing's getting through.
Nothing is getting through. But now at least we have the tinted minerals that are great. Yeah. But, you know, you really just have to be so strict with the sun, because I always say that I can treat your melasma and I can make it go away, but you walk down Lincoln Road for 10 minutes without sunscreen, it's coming back that night.
Exactly.
The next day.
Oh, I know this. And listen, one of my favorite things to do is to be on a yacht. Like every summer.
I know.
I just want to be on a yacht.
I love it.
But I know that I'm going to, you know, have like a whole process. People watch me sometimes on the boat. Like obviously you see only like my pictures and stuff, and it seems like maybe I was out in the sun the whole time. But what people don't realize is I haven't been. Like I start off the day, like if maybe it's morning, so like the UV's not as high, so maybe I'll be like a little bit more like free to roam the boat. But as the sun's like we're getting like midday, I am under the shade. I'll never go on a boat that doesn't have a shaded area or an indoor area.
Neither will I,
because I have to like I can't be in the sun just like endlessly for a whole day. It's just not going to happen. You'll never catch me doing that. So I'll be like under the shade for a while with all my sunscreen, with my hat, with my scarf even.
Right.
And so I have a lot of things happening and people don't realize that. And then later, like as the sun's setting, that's when you find me go out on the front of the boat like that, because I'm not sun tanning.
Right. I have a little trick for you.
Okay.
So if you get a lot of sun exposure during the day, sometimes I'll use an anti-inflammatory at night to kind of calm the skin down. So those are generally prescriptions, but there are a lot of either topical steroid like hydrocortisone, but now we have lots of steroid-free anti-inflammatories that are safe on the face. So I will tell my patients, if you're going to spend the day on the boat that night and for the next few days, use anti-inflammatories, because I always say when we're managing melasma, we want the melanocytes to be fast asleep. We want the skin to be fast asleep. So you don't want your skin to be in this pro-inflammatory state. So I always tell my patients, if you're going to spend a lot of time outside at night, use something anti-inflammatory, really calm it down.
So you said hydrocortisone. What would be another example of this?
So the generic names would be like tacrolimus, pimecrolimus. They're usually used for eczema, but they're safe on the face. There's one called Roflumilast. The brand name is Zoryve, because that doesn't come in a generic. The first two come in generics. The Zoryve is in a generic. There's another one called topical ruxolitinib, and that is Opzelura. All of those are safe on the face, anti-inflammatory. And I use a lot of anti-inflammatories when I'm treating melasma because I want, like I said, the skin to be fast asleep. I don't want any inflammation, no inflammatory cells swimming around in the skin. I just want everything shut down so I can turn off that factory.
So speak to your dermatologist for those kinds of prescriptions?
Definitely, yes.
Yeah, that makes sense.
Yes.
But maybe some of them they'll have to explain why they want
They'd
this,
have
right?
to explain because this is off-label use. I'm a specialist. This is all I do. So I have my little tips and tricks that I do.
This is one of the best tips I've ever heard.
Yes.
Like ever. And I've been doing this for how long?
Yes.
I've been in this industry forever.
Decades, yes. So, I mean, it's one of my tips. It's something that I have to have these little tricks because I'm in like a referral-based practice where everyone who's come to me has seen a lot of other people. And so I have to make the magic happen.
I love that. I love that so much. So this is one of the tougher ones. When I was pregnant, I felt like I wasn't allowed to use anything. Like it started feeling, the only thing I could use at the time was niacinamide. Right. And I became so obsessed with it that it became one of the main ingredients of my skincare line in the beginning. Right. But I feel like so many women that are pregnant or even breastfeeding, they feel pretty helpless. And I hear so many of them tell me that they're just going to let everything bad happen to their face and then they'll deal with it afterwards. What are your thoughts on that?
So you don't have to do that. Okay. There are a few things that we can actually use in pregnancy. Okay. So the main one that I use a lot of is azelaic acid. Azelaic acid, I used to tell people it was an ingredient in cornflakes. Yep. So it comes from it's like a byproduct of a fungus. So it's completely benign. It's very, very safe. By prescription, it's available in 15 and 20%, but over the counter, it's available in 10% formulations, and it works beautifully. So I use a lot of azelaic acid, and I love it because it's safe in pregnancy, and I also love it because it's available over the counter. So if my prescription isn't covered for whatever reason, patients can buy it over the counter. The only downside of azelaic acid, it can be a little bit drying. So I do use a very good moisturizer, and I warn the patient in advance. You can feel a little dry, might get a little irritated. So make sure you're using a moisturizer or one of the topical anti-inflammatories that I typically prescribe to keep the skin fast asleep, right, while I'm treating it. So that's one of the main ingredients I use for my patients with melasma who are pregnant. Another ingredient you can use is mandelic acid. It's a very large molecule, so it's not really absorbed, but it has exfoliating properties, and it's something that can really work well for patients with melasma. There's a new product that was developed by a friend of mine, Dr. Laura Scott. It's called Courage, which is a mandelic acid-based serum that's designed specifically for women who are pregnant or right after pregnancy and breastfeeding, because that's another time where you really can't do much, right? Right. So people are hesitant to write retinoids and things like that when people are breastfeeding. It's the same thing. It's like this 2-year process where you don't get to take care of yourself.
And your skin's freaking out the most because your hormones are going
exactly.
crazy.
So that's an ingredient that I feel very comfortable with. So there are some ingredients that we can use. It is a challenge, definitely. And you can always obviously be really great with sunscreen. That's another thing that you can do.
Right. Oh my gosh. I was so diligent. That was when you never saw my face outside. I was covered in big sunglasses, hat, scarf, all of the things.
Yeah. That's how you have to be for the best results. Yeah. The people who are the most compliant in that respect definitely have the best results.
Yeah, for sure. Are there any procedures, treatments that pregnant women can do?
I guess pregnant women could do the hydrofacial. They could do microneedling, not necessarily with microneedling when they use a topical added to it, but just regular microneedling with, a straightforward serum.
Wait, so you're okay with microneedling when it comes to hyperpigmentation?
Well, okay, so that's a very good point. In the clinical research that's been published in the literature, microneedling has been used specifically as a huge case series out of Brazil as a treatment for melasma. That being said, in my practice, we don't use it as a primary treatment for melasma, and it really depends on the clinician's comfort level. But if someone was highly motivated, first of all, the superficial microneedling may be okay, but you're right. That's a very good point that you bring up. It's not something that I personally do because you can tell I'm very risk averse, but there are large case series published in the literature showing in Brazil, showing that microneedling can be used as a treatment for melasma, although I personally don't do it. So I would feel more comfortable with things like hydrofacials, microdermabrasion, maybe something like that, but really more like very lightweight type procedures.
Yeah, these are like just like more like just clearing the pores.
Yes, it's not, when women are pregnant, they are quite limited by what they can do.
Yeah. What's funny, the reason I asked that about microneedling was because I was such a huge fan of it. And then after my second pregnancy, I was still breastfeeding. I went in to my usual person to get like real microneedling done, like where they use the pen and stuff. And then I had a massive melasma flare, and it had never happened to me before. I think people forget that sometimes your skin can just be different.
Right.
Like it might have worked for you before, but then that was crazy to me. Like I'd never experienced that.
Maybe it was a little bit deeper than typical. Maybe your skin was already in a slightly aggravated state. So there's so many things that could have contributed to why that happens. And that's typical with melasma, because melasma is something that people have for decades.
Yep.
So people will tell me exactly that. I've done 3 or 4. I've heard that story so many times. Like I did this laser 2 times and I had no issues. And then the 3rd time I had a rebound of my melasma, or I did this procedure. That's typical. Or this used to work and it doesn't work. So with melasma, I do a lot of cycling. So usually if someone comes in for their first visit, now I don't use it as much, but they might get hydroquinone for the first 4 to 6 weeks just as a quick fix, and then products to maintain. But oftentimes I'm cycling those products because they'll say, this was really working, but it stopped, and I'll switch to another one and I'll switch to another active, because, it's always a work in progress. You can never really relax with melasma.
Yeah. This is my last question, because you made me think of this with the anti-inflammatories. You know how so many people are on GLP-1s?
Yes.
Right? And it's supposed to be anti-inflammatory,
yes,
right? Do you find that that's helping people with melasma?
Well, it's a good question because I don't think it's been studied, but you gave me a good idea.
Okay.
I think that GLP-1s are great because they actually decrease probably glycation because people are eating less. They have originally, obviously they were designed for diabetes. Yeah. Now they're used frequently for weight loss. Yeah. And so that people are in a lower glycemic state. They're
lower sugar.
Their sugar levels are going to be lower if they're on a GLP-1. And sugar is bad for our skin because it causes glycation. Glycation is when you get, basically, in a way, it's like caramelizing the skin. That's the best way to describe it. But basically, the collagen fibers in our dermis are affected by the sugar, and it makes the collagen fibers very brittle. So people can have advanced aging and have changes in their skin that are not desirable if they're in this high sugar state. So one aspect of GLP-1s long term is that they may be helpful in the sense that you're not going to get as much glycation in the dermis. The only downside of GLP-1s from a skin perspective is that when people lose a lot of weight, there's skin laxity. And that's a common complaint I definitely see in my practice. But this is very early, and I think we're going to see some studies on this. But I've been in big groups of dermatologists and ad boards, and we've discussed it. And some derms think that GLP-1s do have a beneficial effect in the skin. I think that's probably due to like reduction in the pro-inflammatory sugar circulating in the blood system. So some people think that people on GLP-1s do get a little bit of a glow. Huh. And although that's really anecdotal and not based on any scientific study.
There's no true proof.
Yes. Probably the most common complaint would be loose skin with a lot of weight loss, which happens with any type of weight loss.
That makes sense. Well, this is so much fun. I could talk to you for hours about what we're going to do about my melasma. So thank you for joining us.
Thank you.
Where can people find you?
So you can find me on Instagram and on TikTok at Dr. Heather MD. I also have a website called Derm Friends, and it's a weekly newsletter. So if you're a skincare guru and you want to stay up to date on all things skincare, you can subscribe to my newsletter, which is dermfriends.com.
Love that. Thank you so much.
Thank you.
Thanks for tuning into this episode of Glow Lab. If you enjoyed it, make sure to leave a review, share it with your friends, give it a like on social media, and it's all so we can continue giving you really great episodes and bring you on some really great guests.